Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Insight Corporation.
This program is presented by Medscape Education Global.
Hello, I'm Lori Sen. I'm chair of the Lymphoma Tumor Group at BC Cancer and the University of British Columbia in Vancouver, Canada. Welcome to this program titled Managing Diffuse Large B-Cell Lymphoma at First Relapse, Optimizing Patient-Centered Care. Joining me today are Eva Gonzalez-Barca, who is Chief of the Lymphoma Unit at the Catalana Institute of Oncology in Barcelona, Spain, and Natasha Bolanos, who is Head of Membership and Alliances at the Lymphoma Coalition based in Madrid, Spain. Welcome both of you for joining us today. In this activity, we're going to briefly review the clinical trial data supporting the therapies available for treating patients with diffuse large B-cell lymphoma at first relapse. We'll then discuss the factors that need to be considered when making treatment decisions, particularly focusing on a shared decision-making approach with the patient. And then finally, we'll finish our discussion with some patient examples. So to start, we're going to talk about some of the treatment options available today for patients at first relapse. Eva, would you like to go ahead?
Thank you very much, Lori, for your introduction. Okay, I will talk a little bit about the options that we have today to treat patients in first relapse with DLBCL. The first question we have to ask when we see a patient with the first relapse is if this relapse has happened in 1 year or after 1 year of complete remission, because if the patient has refractory disease of a disease relapsing in less than 1 year, we have to think about CAR T-cell therapy for these patients. We have strong data about the benefit of these CAR Ts in this setting. We have two clinical trials with the SUMA-7 and Transform trial, first one with Axi-cell and the second one with Liso-cell. And in both, the remission rate of these patients is very high, around more than 80% of the patients respond, and around 70% achieve a complete remission. And when patients receive these CAR Ts, the median PF, progression-free survival, is around 15 months for Axi-cell and is not reached for Liso-cell. So this is the best option we have for patients refractory or relapsed before 1 year. For the patients relapsing after 1 year of complete remission, the setting is different. Now there are clinical trials also analyzing the value of CAR Ts in this setting, but right now, nowadays, we don't have this option. And we have to ask us the second question, that is if the patient is suitable for autologous stem cell transplant for salvage therapy and autologous transplant. We know that around half of the patients will be suitable for transplant. Around half of these patients will respond to salvage therapy, and around half of the patients who got an autologous transplant will have a prolonged complete remission, or even we can consider them cured. So we salvage a few patients, but still is a curable option for these patients. And then we have the last group of patients relapsing from longer than 1 year, not suitable for being transplanted. And so for these patients, we have now several options. We have the classical immunochemotherapy that we have had for many years right now. The more used are the RGMOX regimen. We have to, there are not many trials with this combination, but there's a phase 2 trial, and we have to expect around 40% of complete remissions, but a very short progression-free survival of around 5 months. So it's immunotherapy can control the disease, but it doesn't cure the disease, and PFS is very short. We have also the combination bendamustine rituximab. Also, there's a small phase 2 trial from the USA, from 13 older patients not candidate to transplant. And with our bendamustine, we can achieve a very low rate of complete remissions, around 15%, and a median PFS of around 4 months. We have now in the last few years new combinations. The combination polatuzumab bendamustine, and with this combination, the complete remission rate is quite high, 74%, and a median PFS for patients in second line and first relapse is around 12 months. So we are improving this PFS quite a lot with adding polatuzumab to the combination bendamustine. And we have also the combination tafasitamab lenalidomide. With this combination, I only think that it's important to remark that in this trial, primary refractory patients were not included, but the complete remission rate was also very, very high. It's around 50% of the patients achieved a complete remission, and median progression-free survival for patients in second line was around 2 years, around 24 months. So have improved very much the PFS rates when compared with standard immunochemotherapy. In this meeting, we have a real-world results of tafalena with very good outcomes in patients relapsed later than 1 year from different groups. We also have results of real-world data about Pola Arbenda, also with results very similar to those obtained in the trials. So at least in Europe, these are the options that are approved and that we can use for patients in second line DLBCL patients.
Great. Thank you, Eva, for summarizing that very concisely. And you know, what we're seeing is that there are numerous options, and we need to think through the patient scenario to consider the best option. We also know that, you know, there are many novel therapies that are in development and have been developed, some of them mainly approved for the third line setting and beyond, although we know that there are active clinical trials that are trying to move these novel therapies into the second line. So the STARGLO trial, which actually combined glofitamab with GemOx, is actually reporting out data, and that will be very important to pay attention to. But we also have a trial of the epcoritamab versus investigator choice of chemoimmunotherapy. There's a trial investigating loncastuximab and rituximab as a non-chemotherapy option against chemoimmunotherapy, and a trial looking at the combination of selinexor with RGDP versus RGDP. But in the meantime, when we do think about selecting second-line therapy for patients with DLBCL, it's important to also think about what factors are important for given patients and for patients themselves. So, Natasha, maybe you can talk to us about how do we consider the patient-related factors in our decision-making, and how do we bring patients into that decision-making process?
Thanks for raising this question. At Lymphoma Coalition, we generate patient experience data. So what I will present today is evidence that we gathered through the Global Patient Survey on Lymphomas and CLL. That's a biennial online survey. And in 2022, we received a total of over 8,000 responses, including over 7,000 patients and 1,500 caregivers. There were more than 1,000 respondents with diffuse large B-cell lymphoma and 262 reported having relapsed refractory disease. And so when it comes to expectations of the treatment, patients rank cure as the top priority. But we know that we cannot offer curative treatment. So it's important to know that patients prioritize improving their quality of life and reducing the side effect burden equally. This indicates that while controlling the disease is crucial, maintaining a good quality of life and managing the side effects are equally important to patients. And that underscores the importance of balancing efficacy with quality of life in treatment plans. When it comes to decision making, this slide focuses on decision-making preferences of patients with relapsed refractory diffuse large B-cell lymphoma, and our survey found that 51% of patients consider it very important for their doctors to ask about their preferences for the level of information they receive and their involvement in care and decision-making. So they can be respectful to what extent they want to be part of that or who should be participating, because patients clearly prefer, and that's what the patient experience data prove, to be actively involved in healthcare decisions. But many want to be more informed about the processes, the stages of their care. Almost 50% of the patients feel that the final decision should be made jointly between them and the doctors, but 1 out of 3 patients also look for the involvement of their caregivers, the family members that are offering them that support system in their care journey. And we also ask about the strategies, what your doctor do to encourage your participation in care decision-making, just to know how they reflect the experience with working with their doctors for that. And 67% value when their doctors allows them to express themselves without interrupting, which is not common. And other important factors include explaining care plans clearly, and treatment choices. And when we talk about treatment choices, it's not necessarily to say treatment A versus treatment B. No, it's really coming into the details, what entails in terms of logistics, in terms of burden, in terms of adverse effects, potential persistent adverse effects once the treatment ends, communicating with empathy, all these factors, encouraging the questions, and check back, what did you get from what I explained? So those are values that are essential for fostering that collaborative healthcare environment. And patients also want their doctors to identify or to recommend other resources and other support they can get access to, for instance, patient organizations. So I would strongly recommend not only to refer the patients to the patient organizations, but also for the doctors to connect with the patient organizations, because they are excellent sources of information, and they can also provide a network of peer-to-peer support. And that's important because the expectations of 80% of the patients is to get also self-management tools. These tools really empower them to take an active role in managing their health, and that they keep certain level of control in a moment where it seems that, everything gets lost. And this really contributes to overall well-being. And when it comes to how informed or patients are, not all of them feel that they have enough information in comparison to what they would like to have. But what I want to raise is that more than 80% of the patients prefer doctors and healthcare professionals as their main source of information. So they are really expecting to get best information from the doctors. Followed by internet is about almost 50% of the patients. So another important advice I could give is ensure that they recognize what are the reliable sources of information over internet, and of course the patient organization. And it's also important to know, what other things may support. So printed materials continue being essential for many patients. When it comes to quality of life, I really want to raise that a shocking 87% of the patients experience psychosocial issues, including anxiety, depression, isolation, and fear of relapse and progression is a major issue for 62% of the patients. Once patients relapse once, they will have that kind of thinking, when I would relapse again. So it's important to provide holistic care, to do early assessments on these psychological issues, so you can refer patients to get the support they need, to social work services, and again, to patient organizations that can offer also that peer-to-peer support or patient support groups and beyond that. Don't forget that among the barriers for accessing treatment is not only the treatments to be approved or not, is barriers concerning language, is health literacy, is financial difficulties for all those hidden costs that are not necessarily visible, how I need to pay for the parking if I come several times to the hospital. So those financial difficulties, it's important that we help patients to understand what is in there. So here I have some takeaway messages. I just want to highlight that there are also uncertainties when we present the treatment benefits or the price concerning quality of life. Try to use patients appreciate plain language, so you also are respectful. Doctors are respectful to their language and talk to them as equals. Honest, transparent conversations, prioritizing the treatment choices and really make them feel like that this is about a patient-centered approach that could transform, if not their disease, the course of the disease. I'm sure that at least can provide better patient experience with dignity and hope.
Thank you. I think you've raised some tremendously important points, and I think the Lymphoma Coalition serves an important purpose in really canvassing the patient experience worldwide. And I think there's a lot of information for physicians to take away from these surveys and the information that you've gleaned and reviewed. As a physician, Ava, how do you ensure that you get your patient's thought on the treatment selection?
I think we have to talk with the patient from the beginning, and now I think that in the last 10 years we talk more and more with the patient, and they are implicated also in the decision making process, and of course, if we are talking with a very young patient, I'm going to try to convince this patient to get the best option. But although this could be a toxic option, but if it is going to cure the patient, I think for a young patient and for a fit patient, this is the best. And I will explain to the patient this possibility of to be cured. And for the other patients, where we can talk about the different options and different side effects, and as Natasha has been talking about logistic problems, about family coming with them, coming and going sometimes from places that are very far from the hospital. So I think in this situation, we have to take in account many other things.
I think you're absolutely correct. I mean, patients have different goals, different priorities. We see many patients of different ages and comorbidities. So there are many factors to consider. I know, in my own clinic, I try to have these in-depth discussions. And one question I always ask is, do you have any more questions for me? But Natasha, you mentioned one question I think is super important, and that is, what did you understand about what I just said? And that's a question I don't ask enough. I think when you ask patients to feed back what you just discussed with them, then you really start to appreciate how they've interpreted what you said, and it gives you a second opportunity to make sure that you're really getting the clear message across. So, Natasha, what advice would you give to healthcare providers to really encourage that positive communication to ensure that they're engaging their patients into these decisions?
Just, to follow a dialogue. That's the key factor, that this should be a constant, you give a message and you get back a message from the patient. So there is an interaction. It's not the patient passively listening and just responding some questions. No. This should be also about really digging into their needs, really into the vital moment they live. What are the incentives to stay alive or to live longer, or why they prioritize quality of life. So it's about really making good questions so you get good answers from them, and they can really express freely without any fear to enter into judgments.
Excellent discussion. Why don't we go forward and consider some patient scenarios, many of which we encounter in the clinics every day. So our first case is a 76-year-old woman who presented 3 years ago with DLBCL, whose FISH testing did not show a MYC rearrangement. She had stage 3B disease and an IPI score of 3. Her past medical history includes nephrolithiasis and endometrial cancer 15 years ago, but she's presumed to be disease-free following a hysterectomy and radiotherapy. She received R-CHOP every 21 days for 6 cycles as per standard of care, and she obtained a complete remission with therapy. Unfortunately, 24 months later, she presented with weight loss, anorexia, night sweats, and fevers. Her ECOG performance status is still a 1. Her examination actually was fairly unremarkable. Her LDH and beta-2 microglobulin were normal, but unfortunately, PET scan and biopsy confirmed relapse disease. So, Eva, which therapies would you consider for this patient and why?
Okay, we are talking about an old woman, 76-year-old, with DLBCL without high-risk molecular rearrangement or studies, and relapsing 2 years after a complete remission. So at this point, for this woman with not very important comorbidities, but probably I will go with tafalena for this woman because she's a good candidate for this treatment. She has relapsed 2 years later. She has a not very bulky disease. She's still doing well. Probably this is the kind of patient that can respond well to tafalena and have a very long remission. We can also use immunochemotherapy like RG-MOX with this patient, but we probably will expect a shorter PFS with chemotherapy. And at this point, of course, it's not a candidate for autologous transplant because of the age. Mainly, and at least in our hospital, and this is not either a candidate right now for a CAR-T because the relapse time is longer than 1 year. So probably with this patient, I will propose her to be treated with tafalena. Yes.
Mm-hmm. Yeah, I would tend to agree with you. I think that this patient definitely would not be considered for transplantation in my setting. She might be a CAR T-cell candidate, but as you said, she's a delayed relapse, so not primary refractory and somebody who's had a nice prolonged response, but unfortunately has relapsed in a more delayed fashion. So many of these patients, as you know, they don't really want to go back to chemoimmunotherapy. I think non-chemotherapy-based approaches are very attractive, particularly for elderly patients. And tafalena, with the data that you presented earlier, I think represents an excellent option given her delayed relapse. Natasha, what do you think are some of the expectations for the patient at this point? What are they hoping to hear from the conversations that they have with their physicians to help them decide on the right therapy?
In addition to present, the therapeutic benefits and all these things, I think it's important to check on those potentially persistent adverse effects still from the R-CHOP. If there is anything that is disturbing her, that, you know, that is particularly hard, that hasn't come back to normal, let's say, you know. And especially because she is an ECOG 1, so you don't want that to deteriorate. And I would put that in the context, what to expect from the new treatment. You know, with Lena, I don't know, are there any risk for peripheral neuropathy? Because at that age, when you can start, you know, like decreasing your ability for certain things, and I'm thinking namely of the gait, of the grip, you know, those kind of things. Even what are your hobbies, you know, for a woman that age, you know, what she does on her daily life. It's important, because if any of the new adverse effects with the new treatment can deteriorate her ability to continue doing that, for instance, for a piano player, you know, a peripheral neuropathy is massively impacting. So those kind of things, so again, it's not what she expects to listen, it's what should be in that dialogue. So to check, to have those checkpoints on what could have a big impact for her on their daily life.
Mm-hmm. You know, I think you've raised a really important point, and that is that different toxicities are or have different relevance for different patients depending on who they are and what they do, and of course their priorities. So Eva, assuming that you'd be selecting tafasitamab and lenalidomide for this patient, what information do you think that the patient needs to be aware of in terms of potential toxicities and adverse events so that they can be fully informed?
Okay, for my patients, I usually explain the main side effects, and then I let the nurse to explain other side effects, just to point out what I think that can be more severe. So for this patient, I will not explain from the beginning the neuropathy, because surprisingly in these patients, peripheral neuropathy with lenalidomide is not so frequent, it's much more frequent in the myeloma patients. And the first thing I will explain to her will be the risk of having fever, and that fever can mean that she has an infection, and that an infection in a patient without neutrophils can be a severe complication if she doesn't go quickly to the hospital. So probably this is the first thing I will explain her. I also will explain her that this is not a very comfortable treatment, because she has to get an IV injection every 15 days for until progression or toxicity. But this is not a side effect. And then, of course, we will talk about fatigue, about gastrointestinal intolerance, about sometimes some kind of diarrhea. But mainly, I will explain here the risk of severe infections in this setting. Yes.
Okay, let's move to the next case, which is an 83-year-old female patient who has a high-grade B-cell lymphoma with both MYC and BCL2 rearrangements. She has, despite her age, no real significant comorbidities, an ECOG performance status of 1. She actually presented and was treated with 6 cycles of R-CHOP about a year ago, but now 12 months later, unfortunately, a PET-CT scan has confirmed a new mass in the pelvis, and biopsy has demonstrated recurrent disease. So, Eva, which therapies would you consider in this patient?
Well, now we have an old patient, an old woman with a very high-risk disease. Again, she has a double hit, high-grade lymphoma, relapsed in 1 year. And so this is, very, very, I think is one of the worst condition in this setting. So what do we have? We have CAR-Ts, and we know for different studies that we can use these therapies in all people, and the results are not different. And indeed, we have now results from the French group that they they analyze this group of patients older than 75 treated with CAR-Ts, and they don't find differences between this group of older patients comparing with the youngest. So probably I will try to do a CAR-T for this patient, but of course we have many other conditions here because she is not young. She needs help probably for many more things than a young patient. So she can have many other problems, as logistic problems, caregiver problems. Well, I will try to use a CAR in this woman, but of course we have to think that if this is not okay for her, we have to use another therapies, another options, and again we have immunochemotherapy or tafalena. I probably will not use pola arbenda in this patient; it's too toxic, probably. So I will go first with CAR-Ts if it is possible, and then probably with tafalena again.
Mm-hmm. I think you're right. I mean, this patient has a range of treatment options. Although she's 83, she doesn't have any comorbidities. In my own clinical setting, we don't have an age limit for CAR-T. As you've stated, there's a lot of data to suggest that older patients can tolerate CAR-T and have successful outcomes similar to younger patients. So being probably the best choice to offer a curative option, I agree. I would be discussing the possibility of CAR-T. Alternative to CAR-T, I think I'd be weighing in tafasitamab, lenalidomide versus pola-BR. So I do use a fair amount of pola-BR. This is a patient with relatively early relapse. Whether or not you define her as primary refractory, probably not, but we know that tafasitamab, lenalidomide works better for more delayed relapses. So I think both are potential options for her, but of course one is, again, bringing in chemotherapy, and the tafasitamab, lenalidomide offers more of an immunotherapy approach. So, Natasha, what do you think is important right now to bring the patient and their priorities into this decision-making process?
It's about asking for her expectations for a new treatment. What is the most important thing for her? What is the second most important thing for her? Is there anyone else that should be part of this discussion? Anyone from the family, anyone understanding also the implications for that third person, especially for that support system that I was referring and before. So it's about presenting that therapy as a full journey. And not only because of the adverse effects, but I would encourage doctors to check on how her daily life looks today and what part of that daily life is really crucial for her. So, and I think that would give a lot of information about, how to present the different therapies, the different risks and the burden of each of these or the potential implications for that quality of life. It has an ECOG one is no comorbidities. You don't want that to change much. You want to preserve, that situation. So it's also something that I think that we need to prioritize. And again, with this age, where the level of anxiety, I'm not telling that for a young person is not the same, but we, as we get older, we think more is logical, no, about end of life. So really present in a very empathetic way and really invite her to make questions, to ask as much as you need, and present also other support for information, written information, refer to a patient organization, try to offer peer-to-peer support so she can discuss also openly with people that can match her characteristics in order to feel, that kind of companion when she's trying to understand what the options are.
For sure. And Eva, if you had to pick the therapy that you would most recommend for this patient, given the fact that she's 83, which therapy would that be? And what are the particularly AEs that would be relevant given her age and scenario?
I think that CAR-Ts for an old patient is hard. They have to be admitted to the hospital. They can have CRS. They can have neurological complications. But after that, if everything goes well, many of the patients continue with cytopenias, risk of infection, immunocytopenias. So the follow-up after the CAR-T sometimes is hard also. So we have to explain to the patient that this is a hard therapy, that she can be cured, but the therapy is toxic, and it's not only for the fact of the infusion, but after the infusion for a long time can be difficult. And at the end, she's 83, so probably the complications, even infections or whatever, are going to be worse in this patient than in a young patient. So it's very difficult. I mean, for me, it's very difficult. I think as you are offering her a curative option, but an option that is going to be hard for the patient. So probably it's very important to know also her opinion, because she can say, I don't want to go through all this. I prefer some kind of more soft therapy and softer therapy and be quiet the rest of my life. So it's difficult. Yep.
Okay, well, to wrap up, I think this has been a very interesting discussion. We've been talking about the complexity of treatment options that we now have in the second-line setting of diffuse large B-cell lymphoma. What we've seen is just an expanding number of options that are available to patients, but these options come with different degrees of intensity and side effects, and the expectations for outcome with these options are also quite different. And I think what's becoming clearer is that not only should we be selecting therapies as physicians for our patients, but we should be selecting these therapies with our patients, and the communication, bringing patients into the decision-making process so that we can understand their priorities and how these different treatments may fit into their expectations is becoming very important. And as physicians, we need to be more cognizant of this, and we need to develop skills and processes to bring our patients into the discussion in a fuller way. So with that, I'd really like to thank both of you, Eva and Natasha, for this excellent discussion today, which I think was very enlightening. I'd like to thank all of the participants in this activity, and I'd like to encourage the participants to please continue forward to answer the questions that follow and to complete the evaluation. Thank you, everybody.
This program was presented by Medscape Education Global.